So good evening, everyone. So we are there with another monthly meet of Arthroscopy Association of UP in collaboration with Varanasi Orthopaedic Association. And we have eminent speakers with us from Varanasi, Dr. Ajeet, Dr. Rohit Pandey, Dr. Abhinay Singh, and our good friend from Coimbatore, Dr. Ramakanth. And we do have a very good panelist and very experienced panelist in form of Dr. Sanjai sir. He's from Lucknow, one of the pioneers of starting arthroscopic surgeries in UP, and Nishith Shah, who has very many publications as far as arthroscopic surgeries are concerned, and he has special interest in PCL surgeries. So without wasting too much of time, I think we should move ahead and get on with our session. So the first lecture is going to be with Dr. Ajeet. Dr. Ajeet, are you ready with your presentation?
Yes, boss. Yes.
Okay, start sharing your screen.
Okay. It's visible?
Yeah, we can see your screen. Okay, go ahead.
Okay. So I would like to thank AAUP for giving me this platform, and a very good evening to all respected seniors and my dear colleague. I'm going to present patellar dislocations and why I switched to basket weave technique. And I have experience of this basket weave technique in adolescent age group population. So prior to that, quickly and briefly, I'll go with patellar dislocation. With this, we can see that this very rare in child, it's common in adolescent age group, and majority of time mechanism of injury is twisting injury or a triadic trauma. It's more common lateral. It can be an acute or recurrent. It can be presented with an osteochondral fracture of patella or a femur. So what makes patella to centralized on trochlea? There should be some bony or anatomical support system or a soft tissue support system which makes patella to stabilize on the central portion of trochlea. If there is deficit in that portion, it leads for patella or it predisposes the patella for the lateral dislocation. So main is if we speak about the bony causes is femoral trochlea. If there is shallow trochlear glue, it may predispose patella for the lateral dislocation, or lateral femoral hypoplasia, patellar shape hypoplastic patella, or higher placed patella or patella alta predisposed for lateral dislocation of patella. Second one is lower limb parallelism. If we speak about lower limb parallelism, it comes with a genu valgum, high Q angle or a genu valgum, excessive femoral torsion or tibial torsion increases the vector forces on patella for dislocation on the lateral side. So soft tissue strain, which stabilize the patella, is a medial one. So medial patellofemoral ligament poses a 60% stabilizing forces. Then medial retinaculum, vastus medialis obliquus. Any pathological lateral structure pull out the patella from the lateral sides like tight vastus lateralis or lateral retinaculum. So how to assess in patellofemoral instability? As we all know that history, whether it's an acute, spontaneous, duration of injury, number of episodes, circumstances of injury, any previous treatment, and we should always look for the ACL injury too in adolescent age group, along with some associated syndrome. Initial investigation for patellofemoral instability is plain X-ray, AP to look for an osteochondral lesion, lateral view, especially in 30° to see the Cochino index in pediatric age group. In adult age group, it's INSAL index. So pediatric age group, it is very much reliable. We can go for a merchant view. Merchant view will give us an idea about sulcus angle, so we can see whether the trochlea is shallow, or we can even classify with this trochlear hypoplasia. Then we can go for a congruence angle where we can assess the relatively position of patellar apex with the trochlear groove. Another measurement is CT, where we can measure the distance between the tibial tubercle to the trochlear groove. More lateralization of patella, it means if there is an abnormality more than 20 mm, it poses the patella for the lateral dislocation. So basically, if we want to divide a patellar dislocation, it fall into two groups. One group is a patient where there is a laxicity positive, crossing sign positive, or there is a more anatomical disturbance which causes the patella for the lateral dislocation. Like if there is a TTTG difference more than 20 mm, you have to medialize the tibial tubercle. If patella is higherly placed, then you have to lower down the tibial tubercle. If tilt is more than 20 degrees, then you have to do a ligament balancing and MPFL reconstruction. The other group of the patient where it is a pure traumatic one and there is no laxicity, if MRI is negative, it can be very well treated conservatively. Most of the time, if it is present with a cartilage fragment or chondritis, you can treat it with an arthroscopic technique. So here we are going to speak about the MPFL reconstruction. MPFL is a broad ligament. It has a femoral and patellar attachment. Femoral attachment usually lies 1.9 mm distal and anterior to the adductor tubercle, or roughly we can say that line joining adductor tubercle to the medial epicondyle, it falls slightly anterior to it. While patellar attachment, we can see that it occupies almost 50 to 60% of the medial patellar region, and the superior most insertion of MPFL interdigitate with the vastus intermedius. So almost all technique, which is implant-based technique, cannot reciprocate the superior insertion of the MPFL because it interdigitate with vastus intermedius. So that's why the basket weave techniques comes in a picture, because this is the one technique which reciprocate the superior most insertion of the patellar insertion. The another technique which is almost similar patellar attachment is superficial quadriceps tendon technique by Dr. Deepak Goyal, which is almost reciprocate the patellar insertion of MPFL. So basket weave technique, MPFL reconstruction has been in procedure of management in recurrent lateral dislocation of patella. Majority of technique has described either implant or a bony terminal for MPFL graft, but basket weave technique doesn't require any implant or bony tunnel for the reconstruction. So it has a great advantage in adolescent population, and it is a complete soft tissue procedure. So here I'm just going with a case. It's a 12 years old female. She has a history of twisting trauma, direct blow. And post that, she has a patellar apprehension positive. She has an instability kind of symptom that knee joint will open up, and patellar tilting was present. There was some trochlear dysplasia too. So here we can go with the case. If you can see, there is a near normal lower limb parallelism with the almost normal genu-valgum. On skyline or merchant view, where we can see there is a shallow trochlear groove with a patellar tilting. So MPFL, the first step is to take the graft, which is a gracilis. It should be minimum of 210 mm. If there is an insufficient length, then we can shift to semi-T. Otherwise, gracilis is sufficient. Now we have to make two incision of approximately 2 centimeter, one over the medial patellar side, another over between the adductor tubercle and the medial epicondyle. The superior incision, we have to make another, we have to incise the medial retinaculum so that we can find out the space between layer 1 and layer 2, where there is an attachment of the MPFL. While the medial most incision, we have to palpate the adductor tubercle and medial epicondyle. Again, there is less use of fluoroscopy in this case, because if you palpate adductor longus, the first bony prominence is felt is adductor tubercle. The second bony prominence you can feel is a medial epicondyle. So it is a saddle-shaped bridge which present between the adductor tubercle and medial epicondyle. After incising that, we have to elevate almost 1 centimeter of ligamento-periosteal sleeve. It is a soft tissue bridge which present between the adductor tubercle and medial epicondyle. So this graphical picture I have taken from the same paper of Dr. Pranjal. So here what you have to do is, after elevating the 1 centimeter of thick ligamento-periosteal tube with the help of mixture forceps, you have to loop around the graft through this osteoperiosteal sleeve. And you have to stitch with the precision stitch over the ligamento-periosteal sleeve. Second step, you have to retrieve the graft from medial incision placed over the patella from the incision placed on the medial side of the knee. And for that, they have used a specific instrument, which is tissue passer along with the graft retriever. Here I have used a straight mosquito. After retrieving the graft from the medial incision, there is a technique where the basket weave technique or suturing technique comes in a picture. Here we have to I'll show the graphical presentation. Over the superior portion of the patella, we have to make vertical incision 1 centimeter apart over the superior pole of the patella and elevate the alternate ligamento-periosteal sleeve. So we have to pass the ligament, the ligament beneath and over the ligamento-periosteal sleeve. So elevate the alternate ligamento-periosteal sleeve and pass this graft and stitch with precision technique. So here the superior limb, because now we have 2 limbs of the graft which we have retrieved from the anterior skin incision, and the superior limb of the graft should be tightened at the 30 degree of the flexion, and the inferior limb of the graft, which we have to tighten on the 90 degree of flexion. So this is again another advantage of this fixation, that you are providing stability of MPFL all along the knee range of motion, because majority of time in hypoplastic lateral femoral condyle, the displacement of patella lateral sides become abnormal at 90 degree of flexion. So it is kind of a dynamic stabilization of MPFL. Second, the superior fixation will reciprocate the normal anatomical position of the graft. So this is the patient is in spinal. So here we can easily appreciate the tilting of patella, and it's going outside on the summit. After stitching both the limb, you can see the tilt is gone and patella is not moving on the lateral side. So why basket weave? It has a advantage in skeletally immature patient, where you don't want to use any bony tunnels or fixation devices. It is anatomical both in patella and a femoral insertion. No implant used. It's a soft tissue fixation procedure, yet rigid fixation, because it prevents the over constraint on the medial side of the ligament reconstruction, and stability throughout the range. Even it can be used in dysplastic trochlea. So these are the two techniques, the paper from where I have started using this technique. It's a beautiful paper by Dr. Pranjal of basket weave technique. Thank you.
Thank you, Ajeet. A wonderful presentation. Fantastic. We were very fortunate to have Dr. Pranjal with us a few months back, and he highlighted about this technique. So any of the panelists who have used this technique, or the faculties who have used this technique of basket weave, and their comments about it? Any one of the faculty and the panelists?
I've done it in one case. Recently, I came across this paper and gone through this. It is appealing, and I try to do that, and it's a wonderful technique. And as Dr. Ajeet has very clearly pointed out, that no implant is required. That is one advantage. And secondly, it is not a very rigid kind of stabilization, which is important when you are talking about patellofemoral. And third big advantage is you can do differential tightening of both the limbs separately. So, it's a promising technique. I've not done enough cases, but I really feel. I just want to ask one thing to Dr. Ajeet.
Yes, sir.
Did you do lateral release also in this case?
Yes, sir. But because there was an excessive tightening, so I did a lateral release at the end of the procedure.
Yeah, that's what I was wondering, because if patella is relatively hypoplastic and you have dislocating patella, especially subacute or chronic, then lateral release is very, very important. Otherwise, there's a lot of pressure on the medial side and your graft might get lengthened and loosened and fail for a period of time.
Ajeet, any specific problem you would like to mention about this technique? Any specific precaution or a problem that you would like to mention?
That is what you have faced,
So,
any problem?
I feel this technique is good in near normal lower limb parallelism. But what I have mentioned it earlier, all anatomical structure or anatomical stabilizer should be considered. Like if there is a gross anatomical abnormality is present, then definitely this technique is not going to work alone. So we have to correct those prior to this MPFL reconstruction. And technique wise is a very simple and a technique which we can reciprocate in most of the cases. So it's not very technically demanding.
Passing of the graft is easy?
Yes, sir. Passing of the graft is very easy. What we can do is there's good advantage that we don't need even a fluoroscopy. You have to make a thick incision after making a skin and subcutaneous incision from anterior portion of the anterior tubercle to the medial epicondyle, and just elevate that sleeve. And second thing is, after making an incision in the medial retinaculum, that area become very clear for that layer 1 and layer 2. So from both the areas,
I am also talking about the patella.
Passing of the graft is easy. We have to make a thick and broad alternate incision over the superior patella and the middle portion of the patella.
Okay. Ajeet, Dr. Pranjal has his own devised suture.
Yes.
You have that with you?
No, sir. I have used a mosquito.
Anyway, so thank you, Dr. Ajeet. We will move to the second topic now.
One comment.
Yeah, yes, sir.
Once you are doing it on the anterior patella, as I did it in a child, you usually have a good amount of soft tissue on the anterior side. But if you try to do it in an older child and even an adult, you might not get that amount of tissue on the anterior side. I don't know whether that will have bearing on
the periosteum is thicker in a child, so that gives advantage.
Yeah.
Okay. So we can move to the second topic, which is PCL Avulsion. Very many techniques have come up in last few years. We have Dr. Ramakanth from Ganga Hospital, Coimbatore. He is going to talk about.
One question, Vinay, if you permit.
सर इसके लास्ट में ले लेंगे, मतलब सेशन सारे हो जाएं फिर ले लें.
Okay.
हाँ, मतलब once we are finished, we can have all the so because already we are late. So Ramakanth, you're going to talk about arthroscopic management of PCL Avulsion.
Dr. Vinay, can you see my slides?
Yes, it is visible.
Yeah, that's great.
Thank you. So I am Dr. Ramakanth from Ganga Hospital. So first I would like to thank AAUP and Dr. Vinay for giving me this opportunity, and also Sundar sir, from whom I have learned all these techniques. So I'll be sharing my experience. Basically, this talk will be on techniques and tricks to get it right. So Yeah. So we know that PCL avulsion injury happens due to two mechanism of injury. One is like direct blow, like in a dashboard injury where PCL gets avulsed, or in a hyperextension injury where you can see this, there is a contusion and then the PCL gets avulsed. So there are three types of PCL avulsion injuries classified as undisplaced, displaced with a partial hinge, and then completely displaced. So I'll go straight into the case. We had a 33-year-old who presented 10 days after injury with pain and swelling, and clinically there was a gross posterior laxity and posterior sag was there. So this was his presenting X-ray and CT scan. So we can see that there is a complete avulsion of the fragment, and it was a type 3 avulsion. So the fragment was fairly big size, maybe around 1.5 by 1.5 centimeters. And there was a avulsion leading to the posterior laxity. So this was his clinical picture where we can see there is a gross posterior laxity. So PCL avulsion injuries we take up once the swelling reduces, preferably arthroscopic fixation. We can take it up after anywhere after 8 to 10 days where the gross swelling is reduced, and then there is a mid posterior healing happens. So the first is the diagnostic arthroscopy. So in this case, the ACL was intact. So we can see that there is a posterior sag and then sloppy ACL sign. So whenever there is a PCL tear or a PCL avulsion, we see this sloppy ACL sign. The first step is to create the windows for the working portal. So the first is, we know that there are 3 windows in the notch. So with a shaver, and we can use RF probe to create those windows. So the 3 windows for working from front will be like medial window between medial condyle and PCL. This will be like a notch window between ACL and PCL, and then the lateral window. So for PCL avulsion, we don't need a lateral window. So we mainly need a medial window and the notch window. So once we go through the notch and then window is created and the septum is cleared, so we need a 2 posteromedial portal. One will be the high posteromedial, and then the lower will be the lower posteromedial. So we need a 2 posteromedial portal. So one will be for the viewing portal, that is a high posteromedial portal, and the lower one will be for the working posteromedial portal. So first thing is to clear the soft tissues around after clearing the septum, and also a little bit of capsular attachment and all the soft tissues on the posterior aspect of the fragment as well as on the posterior aspect of the tibia. So this is the view from the posteromedial portal. So we use a probe or a Visinger rod and then check for the fragment, the size of it, whether it is comminuted. And then after clearing with the RF probe, we can clearly see that the mobility of the fragment from the posteromedial portal. So I am viewing from the higher posteromedial portal, and then the Visinger rod is passed from the lower posteromedial portal. So then to get the tunnels right, we need to clear it on the posterior surface. So here from the anterior, we may not be able to clear the posterior surface of the tibia. So we use RF frequency probe or a shaver, smooth shaver. We can clear the posterior surface of the tibia where we need to get a tunnel. So the tunnels will be on the either side of the fragment. And then the jig is passed from the anterior through these windows. So to the medial tunnel, we can pass in the medial window, and for the lateral tunnel, we can pass through the notch window. So that's how the jig will be passed around the fragment on both the sides. So here again, we will be having 2 tunnels on the either side of the fragment. So this will be the fragment. On the either side of the fragment, we'll have 2 tunnels, one on the medial side and one on the lateral side to the fragment. And here you can see that there is a displacement of the fragment. So this is how the outside picture would look like. The superior one will be for the viewing and lower one for the working. And then the jig is passed. So we need 2 tunnels. So here we can see that we have already passed the 2 KOS with the help of the jig. So we get it across both the sides, and then the KOS with the posterior protection sleeve. So we wall drill it with around 4.5 mm reamer. So once the tunnels are done, then we need to get the fiber tape and the suture tape. So the fiber tape will be passed on either side of the PCL through this medial window and the notch window, and then retrieved in the posteromedial portal. So here we can see that this is a PCL, and then the fiber tape with the ends fiber wire is being passed around the PCL, and then the fiber tape will be retrieved from the posteromedial portal. So you can see that one is going to the notch window and the other one is going to the medial window. Then we pass the scope in through the same window, and then we can see that we are retrieving for the posteromedial portal here. So on either side, the fiber tape is being passed, and then it is slided down to the bony fragment. So and then we go back posteriorly, and then we put a knot with the knot pusher with small non-sliding knot or a simple knot on the posterior surface of the fragment and the PCL, and then the fiber tape is retrieved through both the tunnels. On either side, the fiber tape is retrieved. The suture passer is passed from the anteriorly, and then with the help of the knot pusher, we can negotiate the fiber tape and then get it into the tunnels. So this again, the knot pusher is we getting the fiber tape, and then knot pusher is being pulled out. So here we can see that we pull the fragment and then see the reducibility of the fragment, and then we can reduce it like this. So, and then afterwards, we want a double fixation for the PCL, because to reduce the secondary laxity, and then the fiber wire is being passed in a similar fashion in the notch window, and then into the the medial window, and then both the ends are being again pulled out in the posteromedial portal, from posteromedial portal, and then we get it. So once we get it in the posteromedial portal, so being the fiber wire, we put this endo button, then we pull it across, then it gets easily slided in, and then with the knot pusher or the grasper, we can push it onto the posterior surface of the tibia. Yeah. So the button is being pushed into it. So in the similar fashion, once the button is fast, and the similar fashion with the suture retriever and then the knot pusher, the wires are retrieved through the tunnels, both the tunnels. And then after retrieving through the tunnels, we pull it from the anteriorly and then check the placement of the button. If the button slides in below, we can readjust it on the posterior surface of the fragment and then pull it across. So this is how it will look outside picture. So outside, both the fiber tape and the fiber wire is separately tightened by looking scope in the posterior aspect, and then tightened in the anterior cortex. So for the triple fixation, we put a suture post, and then we can see that four threads will be wound around the suture post for the secure fixation, and also this will add to like a triple fixation. So, and then we can finally check the solid stability. What we had, the gross posterior laxity is gone. So this triple fixation will give a good strength to the PCL avulsion fixation. So this is the immediate post-op, where we can see that button is rightly placed on the posterior surface of the fragment, and then the suture post where the fiber wires are held in. So this is a 3 months follow-up. So we have published our series. We did a randomized control trial for open reduction versus arthroscopic fixation, arthroscopic reduction and fixation, that is ARIF, and then published in KSSTA journal in 2020. So it was a randomized level 2 study we had 20 patients each were grouped and then analyzed for the clinical laxity as well as for the radiological laxity. So both had yielded a good result. Only thing is ORIF was slightly better in terms of cost and duration of surgery. We had few cases of non-union in the arthroscopic, and one case of iatrogenic vascular injury was there in the ARIF group, but it was not statistically significant. It is little technically demanding, so the cost of the surgery and the duration of surgery is more in the ARIF. So the technical tip and trick to get it right is need a 2 posteromedial portal and 2 working windows in the notch, and RF radio frequency band for the clearing posterior substance will give good identification of the fragment and the posterior surface of the tibia. Fiber tape and fiber wire and endo button will give double fixation, and suture post adding a triple fixation, so that the secondary laxity which we see in PCL reconstruction and fixation can be avoided. So for more tips and tricks for various arthroscopic surgery, I would like to invite everyone for IASCon, which is happening next month, exactly 1 month from now. So we have around 18 live surgeries, 18 plus live surgeries on first day, knee, shoulder, elbow, ankle, and wrist. And then another 6 to 7 surgeries on day 2 and day 3. So it's a unique opportunity where we can see all the stars opening. So we have total around 25 to 28 live surgery being planned. So of the important live surgeries, we have ortholetology will be demonstrated by Dr. Ashish Babulkar sir, and we are showing live demonstration for Mendel's allograft transplantation and lower trapezius transplantation. And the president oration will be given by Professor Adrian Wilson from UK. And these are some of the key points where we have good shoulder debates, symposia. We have 4 symposia in shoulder and knee, 1 hour each. So totally 8 symposia will be there. And for other opportunities, like for young people, they can participate in the quiz and then win the complete ACL set will be given as a prize money. And apart from arthroscopy, we also are inviting sports celebrities like cricketer Baichand Bhutia and Abhinav Bindra. So apart from that, our stalwart will give their experience on their own sports life in the sports static talks by Anand Joshi sir, Ashish sir, IPS, Shirish, and Dr. Arumugam sir. So also finally we have a celebrity for the IASCon. Thank you very much.
Thank you, Ramakanth. So we all are looking forward to seeing you in Coimbatore. It's going to be a fantastic event. We know that. You've already done it 2 times, and this is 3rd time. Is going to be super great. Anyway, thank you so much. So we are going to move to the 3rd topic, and then we can have discussion in the end of the session because we are running a little late. So Sanjay sir, can we take the lecture and then we can go with the discussion at the end of the session?
Sure. That would be better. Then
Okay.
let's and then.
So Rohit, are you ready with your presentation about?
Yes.
Okay.
Yes, I am ready.
So you can share your screen.
Is it visible?
Yeah, sure.
So good evening, everyone, and thanks a lot for AAUP and especially Vinay Pandey sir for giving me this platform. So I will be speaking regarding the extra-articular tenodesis, when and how to do it. So regarding the ACL reconstruction, as we all know, that there are so many confusions still present, that whether you want to do a single bundle or a double bundle, trans-tibial or a transportal, you want to use a screw, a staple or a button, all inside, outside, and the type of graft. So just to add to the confusion, I would like to add whether to do an extra-articular or a LET procedure or a ALF procedure with this or not. That will more increase the amount of confusion which we are having currently. So the problem with the last few decades has been that we were too much focused upon the ACL reconstruction, and we are getting quite good at it with time. But the problem with this vision is that you miss all the cool stuff which is present on the outside. So this is a cross-sectional area of the knee joint, which shows that you also have to look in an ACL injury at the capsule, the fibular collateral ligament, and the popliteus tendon. Little bit regarding the anatomy of the same. So the anterolateral soft tissue constraints are basically the capsule, which has the ALL inside it, iliotibial band, and the meniscus and its capsular attachments. It has been described long back, and we all know Seagon's fracture currently. So once you have a Seagon's fracture, you have to assess the ACL, and most of the time there is an ACL injury along with the Seagon's fracture. So regarding its attachment on the femoral side, it is quite variable, but on the tibial, it is mainly in between the Gerdy's tubercle and the fibular head. But you have to know this, that this is basically a thickening in the capsule. So every time you cannot find it, it is just a thickening in the capsule, which is known as an ALL. So why I am moving towards doing an lateral extra-articular tenodesis? So as we all know that in an ACL injury, it's not only about the anterior posterior instability of the knee joint or the anterior translation of the tibia. You also have to look at the rotatory instabilities, which is very much important in a pivoting sport, such as a basketball or a rugby or other high-level athletes for that matter. And we all know that we have seen such patients in which the ACL has been done quite nicely, but still the patients are complaining and their poor functional outcome if the knee is pivoting after the operation. We all know that around 30% of the patients, even after an ACLs, are not very much satisfied, and there is a high failure rate currently in the ACL surgeries. This is a very good paper which demonstrates that especially in a younger, less than 25 years, and in athletes, there is even a higher chance of getting the graft ruptured even after doing a very good ACL. So as you cannot get away with clinical examination, this is the most important part of any procedure. So you should know that how to examine an ACL. So this is a Lockman test in which you see the anterior translation of the tibia. Then you have the anterior draw test. Again, the anterior translation is present. And this is the most important, the pivot shift test. And there is subluxation of the knee on giving internal rotation and the valgus force to the knee. So what are my indications of doing a LET? In a primary situation, if there is a high grade pivot around 2 or 3, high demand patients who wants to represent the country at the highest level, who are athletes and young, persistent rotatory instability even after doing a very good anatomical ACL reconstruction, hyperextension at the knee, and patients with high Brichter score, which is the hyperlaxity quotient. And always I do it in all my revision cases just to provide that extra stability to the knee joint. So why do I prefer an LET and not an ALL? Because there are so many advantages of doing an LET with the TFL that you don't have to harvest any other graft. It is attached at the Gerdy's tubercle, so it provides extra vascularity to the graft. You don't need to drill so many tunnels, and only a minimal graft. I use the modified Lemay technique in which only a screw is extra required. And on the femoral side, you have to make only one tunnel. So regarding LET, it has got multiple modification, but the basic thing remains the same, I guess. So it was initially described in 1975 by Lemay, and further modification came by. Then you have the Macintosh procedure in which you don't require any other extra implant. This can be used in a low demand patients, but the Lemay procedure is the golden standard if you want to do it in a high level athlete. So I would like to describe one of my cases in which I have done a revision ACL with an LET. So she's a 23-year-old decathlon player who had a previous ACL injury 2 years back. She had re-trauma again 1 year after the surgery, and on examination there was pivoting of the knee joint present. You can look at the MRI, and there was little bit of PCL buckling, and the anterior ACL fibers were not very much intact. Means there were only few fibers reported in the MRI, and you can see it on the MRI also. There is a very small fiber located on the MRI film. Regarding the previous tunnel, the femoral tunnel was roundabout all right and not too much malaligned. But on the tibial side, if you have a look, then the tibial tunnel was quite anterior from where it should have been. On clinical examination, while doing the anterior draw, it was roundabout grade 2. And especially the Lockman, when I was doing the Lockman test, the laxity was not much. It was around grade 1 only. But when I was doing the pivot shift test, the knee was quite dislocating, and it was a grade 2 or grade 3 pivot. On arthroscopic examination, when I saw inside with the scope, as you can have a look, that there were few ACL fibers intact, but it was quite lax and not providing any stability to the patient. And as she is a very high level athlete, I decided to go ahead with a revision ACL in a single stage along with an LET procedure. So how I do it, I use the modified Lemieux's technique for the same. So regarding the technique, initially you have to find the bony landmarks. It is the Gerdy's tubercle, the epicondyle, and the fibular head. Then you have to make an incision of around about 10 centimeters. Expose the TFL very nicely and always identify the posterior border of the TFL so that you can get the complete width of the TFL. Then you have to make an incision and a width of around 1 centimeter and a length of around 10 centimeters to harvest the graft distally attached at the Gerdy's tubercle. So here is the graft. It is attached at the Gerdy's tubercle, and then you have to whip stitch it on the proximal end. Identification of fibular collateral is very much important. In a very thin patient, you can identify it very easily from the epicondyle to the fibular head. But if you are having any difficulty, you can make a figure of 4 position, and then you can identify the FCL. Subsequently, you have to make anterior and posterior fibular tunnels, just anterior and posterior to the fibular collateral ligament, and you have to pass the TFL below it. This is not my photograph, but in this case, I would like to show that you have to identify a point 5 mm proximal and posterior to the lateral epicondyle, and then you have to drill a tunnel which is going proximal and anterior so that there is no collision with the previous ACL tunnel which is present there. The direction, as I told, should be proximal and anterior. And while fixing the graft, you have to keep the knee in 30 degrees of flexion with neutral rotation. Initially, it was done in external rotation, but it showed that there is very high lateral compartment pressure because of the same. So it is currently done in 30 degrees of flexion and in neutral rotation. And you have to close the TFL interval afterwards. So this is the post-op X-ray. There was a previous endo button which I didn't remove. And the patient has started her rehab and hopefully she will be fine. And currently she is doing all her exercises and everything with no difficulty in range of motion or any instability. This is another patient who was a Kushti player. Similar procedure was done. Currently is doing all the rehabs and everything, and he is also doing fine. Regarding the range of motion in the scar, there are few case reports of arthrofibrosis after multiligamentous injuries also. So in this case, as you can see, the range of motion is quite good. This patient had a little bit of hypertrophic scar, but most of the patient don't show that much of hypertrophic reactions. The stability, range of motion and everything is perfectly all right. The rehab protocol for the same, you don't need any special restraint. I give the range of motion knee brace in all my ACL patients for initial 4 to 6 weeks with gradual increase in range of motion. As we have, there are few complications also with this procedure which you can find. There can be over tightening of the lateral compartment. You may have a patellofemoral pain. The tunnel collision you have to avoid. Arthrofibrosis and infection can also occur. So this is the initial days when I was doing this surgery. I had few you can say that I was in trouble with few things. So initially what happened is then when I was doing the arthroscopy first, there was quite swelling in the knee and it was very difficult to identify the LCL. And I was getting confused with the gastrocnemius also. So in this case, what I'm doing right now is that initially I give the incision, I identify the LCL, and after that, I just do the arthroscopy and the fixation of the ACL. On the LET side, you don't need to fix on the femoral side initially. You do the ACL and afterwards you can fix, but you can identify the LCL and do rest of the things beforehand. Again, you have to avoid the collision of the tunnel, which should be anterior and proximal directed. And the length of the TFL, it happened once with me that I harvested the graft, but it was not going into the femoral tunnel much. So the length of the TFL, if you take more, it is not a problem. But if it is less, then it may create a little bit of problem. So these are the few papers in which they have shown very good results. This is a paper of 30 patients, which has shown only one failure. And the important thing is in 15 patients, there was no pivoting present at all. Another paper which shows a good result of modified Ellison's procedure. All 35 patients returned to sporting level with one case of re-rupture. And I have one patient which I have seen in my clinic. He was operated with a double bundle ACL, but still he was complaining of while doing the pivot shift test, he was complaining of instability. So this cohort study is a very good study which shows that if we are doing a single bundle along with an LET, it shows better rotational and an ITDC scoring in the patients. ALL and EAT are most commonly having the comparable results, so both the procedures can be done. Just I prefer LET, as I have told before, that you don't need to make extra tunnels or use extra grafts for the same. Change in the patellar kinematics was one thing which was initially a little bit troublesome. So this is a very new paper which shows that initially you have higher contact force while going downhill, but over a period of time that effect is lost. So there is no major complication when you are doing an LET in an ACL reconstruction. So to summarize, rotational stability is very important in an ACL reconstruction. You have to look at the rotational component also. It's not just about the anterior tibial translation. You have to choose your patients very wisely, especially in a young, high level, high demand athletes. It is a very good procedure to be done. Modified lemma is a very good procedure with no extra graft requirement, and you have to prevent over tightening of the lateral compartment. So thank you so much for your patience listening.
Thank you, Rohit. It's a fantastic lecture you have prepared. I must congratulate. So last topic is by Dr. Abhinay from Varanasi. He's a dynamic surgeon who has shifted from Kolkata to Varanasi recently. And his talk is about MCL tibial sided injury, how I manage. Abhinay, are you ready?
I'm ready.
Okay, you can switch over to share your screen.
Hello, good evening. Thanks for giving me the opportunity. Thanks to AAUP. Today's my talk is about MCL, especially on the tibial side injury. MCL is one of the most common ligament injuries of knee. It results from the valgus injury in extended knee or a combination of flexion, valgus, and external rotation injury to the knee. Regarding anatomy, it consists of three structures mainly, that is superficial MCL, deep MCL, and posterior oblique ligament, POL. Superficial MCL, it originates from a single point in femur that is about 3.2 mm and 4.8 mm proximal and posterior to the medial epicondyle. And it inserts at 2 points in tibia. It is 1.2 mm distal to the articular surface and 6.1 mm distal to the articular surface at 2 points. It is fan-shaped insertion. And the second one is deep MCL. It's a capsular thickening attached to the meniscus also. And the third one is the posterior oblique ligament. It is mainly the central portion of the posterior oblique ligament. It's a capsular thickening. These three consist the posteromedial corner of the knee. Regarding classification of the injury to the MCL, as per the Extern classification, there are three grades: grade 1, 2, and 3. In grade 1, there is very mild fiber injury. There is no laxity. In grade 2, there is moderate laxity with little bit more fiber injury, incomplete tear of MCL. And in grade 3, there is complete tear. Further divided into grade 1 plus 2 plus 3 plus as per the valgus stress. There is a new classification introduced in 2018 at Iran in Arch Bone Journals Surgery. It is a MRI-based classification. It is further divided into 5 types. Type 1 is the pre-avulsion injury. There is only contusion in MRI at the medial femoral epicondyle. It is managed conservatively. There is no need of surgery in this case. Regarding type 2 injury, there is avulsion injury at the medial femoral epicondyle. This requires surgery. Type 3 is the mixed substance tear. This type also requires surgery. Then the fourth type is distal detachment of the MCL from the tibia. This also requires surgery. And the fifth type is proximal sleeve rupture of MCL and the capsule that results in the medial condyle of the femur as bottom hole in the capsule. These types 2 to 5, these 4 types always require surgery, and type 1 can be managed conservatively. This is case number one. Case is about a female, 22-year-old female. There is history of fall with valgus injury in extended knee. It's a 2 weeks old injury. She presented to us with medial side pain over knee. And on examination, the valgus test is positive. X-ray was done. MRI was also done. In MRI, there is type 4 injury of the MCL. That is detachment of the medial quarter ligament from the tibial side. You can see the edema and the detachment of the medial quarter ligament from the tibial side in this MRI picture. Now, regarding operative technique, we decided for the MCL repair. These are the steps. First, we give incisions along the pens anteriorness, sartorial fossa. You can see here after dissection of the subcutaneous tissue. Thereafter, we give incision over the sartorius fossa, just proximal to the gracilis and semity tendon. You can see the medial MCL, medial collateral ligament. This is the torn part of the medial collateral ligament. The semity and gracilis are retracted posteriorly. Now the VPC suture is applied at the distal end of the MCL. Anchor at about 1.2 mm distal to the articular surface. A 5.5 double loaded metric anchor was applied, and the scissors went fast from the MCL. First, we fix the proximal part of the MCL at about 30-degree flexion in varus stress. And then we staple the distal part of the MCL. Now the post-op we have, from 0 to 2 weeks, we kept the knee in a long knee brace, and partial weight bearing is allowed with crutches. From 2 weeks, we started range of movement with brace and partial weight bearing. From 4 to 6 weeks, we allowed up to 20 degree. And after from 6 to 8 weeks, full range of movement was allowed. But brace was continued till 8 weeks, that is hinge knee brace. Crutches were discontinued after 8 weeks. Now, case number 2, a 34-year male patient with history of fall while playing football. It's a 3 weeks old injury. It presented to us with instability and medial side pain of knee. Lackman's test was positive. On valgus stage, it was also positive. There is X-ray showing ACL avulsion, and on MRI, there is ACL avulsion and type 4 injury of MCL. Now, we have decided first to go for arthroscopic ACL avulsion fixation. Thereafter, MCL reconstruction. This you can see after arthroscopic ACL fixation, we open the medial side. Here you can see the torn and the frayed MCL that is not repairable. That's why we have decided for reconstruction. This is the laxity. These are the two semity and gracilis tendon. It is distally attached to the tibia. Now we have done the rerouting of the distal of the two tendons, gracilis and semity. We have bring the two tendons at the insertion point of the superficial MCL. Now again, it is stitched at the insertion point of the MCL at the femur, approximately about 3.2 and 4.8 mm proximal and posterior to the medial epicondyle. We drill with a 6 mm reamer up to 30 mm. Thereafter, a screw was inserted. That's at 30 degree of flexion of knee joint. You can see the MCL part. Thereafter, we decided to fix the posterior oblique ligament. This is the part, second limb is the posterior oblique ligament. We have fixed it with a screw. This is the final picture. This is the PUL and this is the MCL. and this is the fixation. The laxity is decreased after this fixation. On the post-op protocol, we started range of motion after 1 or 2 days, and with long wing brace, we allowed passive weight bearing. At 4 to 8 weeks, the range of movement was allowed up to 90 degree. And hinged knee brace. Crutches were discontinued at 8 weeks, but straight head running allowed up from 8 to 12 weeks. But before twist, maneuvers were not allowed up to 12 weeks. Thank you.
Thank you, Abhinay. So very, very nicely presented presentation about essential injuries, chronic as well as acute tibial sided injuries. Before we start with our discussion session, Nishith sir, you have a small video about 3-4 minutes regarding PCL fixation. Nishith sir, are you there? Dr. Nishith? Nishith sir, are you there?
I think he's got disconnected.
Oh, okay. So now we can take a few sessions. Dr. Nishith sir has a small video of PCL as well as ACL reconstruction. He wanted to show us a technique without giving a posterior medial incision. So sometimes it is difficult for people to make.
Okay.
Nishith sir, are you there?
Yes, yes. I am.
Are you ready? Please share your screen.
Is it now okay?
Yeah, you can go ahead. You can go ahead, sir. Please, sir.
Okay. Are you saying it?
Yeah, we can see your screen. It's blank basically.
Okay. So thanks to you all. I enjoyed today's session. Very, very interesting. And the quality of the presentation was excellent. So today, what I'm going to show is that what I was doing before without any posteromedial or posterolateral incisions, but I think that it needs a lot of experience, and I am also now more comfortable with the posteromedial incision. And if it is the old case or revision case or old PCL injury, then I also take both posteromedial and posterolateral approach. So this is just to have something like historical. So this is a PCL reconstruction without posterior portals, and this is a patient whom I did revision ACL and a PCL reconstruction before 3 days. There was no ACL because it was removed already, and you can see the stretch PCL very easily. It was a 2005 surgery, so you can see the partial meniscectomy, medial meniscectomy. The lateral meniscus was okay, but the articular cartilage of the lateral tibial condyle was already damaged. And as there was no, I had to do so I took there was a longus which I don't like, but here I had no option. And the notch was absolutely constricted both the sides for ACL, BCL, because it was like 15 years old. So first thing I did was notchplasty, because then and then I could insert my PCL elevator in the posterior compartment. As you can see here, that it was still difficult, but I could see, and with this, this is a high anteromedial portal. That is why you are able to see in the depth of the tibia and the back. There is no posteromedial or posterolateral incision. Then, as usual, I put the tibial jig, and from the front, like any other PCL reconstruction, the important thing is that you have to have everything under vision. And you can see that now my assistant is hammering the drill tip passing pin, and then on this the graft size. And usually I like to take 1 millimeter more drill than the actual graft size, because that makes my life easy, and it doesn't make any difference in the healing of the graft. And the tunnel is dilated properly, and then for me it is very easy that I pass a wire loop, and with a crochet hook I just try to pull it out through the tibial tunnel to the front of the intercondylar notch, and then outside in femoral tunnel with the femoral jig, and on top, like normally you drill a femoral tunnel. And you clean the tunnel, remove all the, and now usually it becomes like augmentation. And then with a simple technique of one artery forceps and one crochet hook, one can easily pass this wire from tibia to femur, as you can see here. And before I pull the graft, I usually pass the pin, and then you pass the graft, because I use usually a bio screw to fix. And this is the peroneus longus 9 mm graft coming in the vision. So this is the new PCL fixed with the bio screw. And then I did a ACL bone patella bone reconstruction, fixed also with the bio screw on the femoral side. Very robust graft. And then 90-degree flexion, bioscope fixation of the PCL. And also, so these are the incisions, and this is the PCL tibial tunnel you can see here, and this is the ACL tibial tunnel. Then the next day, patient was able to do. So this is what my presentation was. And shall I go ahead and for the tips?
Yes, sir. Sure.
Okay. So how to do more successful PCL reconstruction, and this is all my experience of so many years that I'm just doing this. The first thing is that you have to have a high inflow, and this is what my trolley is, and I can do it around 6-7 feet, and this is always 2 bottles simultaneously going on if I have to do a PCL, and at least 5 or 6 bottles are kept inside the theater. So nobody has to run out and nobody has to call. And with this, my fluid pressure pump has become redundant. So if somebody wants it, I'm ready to give it to my friend. So because I have not used it for last 5 years. You take multiple portals and especially the posterolateral portal. So usually you should tie something on your knife, and so knife will not disappear, because that becomes very much problematic if you have to remove that broken part of the knife, IITV and most things. So don't take these chances. And usually I put this is the camera bag's yellow sticking thing comes in, and that is what you put it. Normal under portal, middle portal will not give you visualization of this area where the PCL is attached. And if you do that portal, then you have to do high anteromedial portal so that you can see this area very nicely like this. And that is what usually my portal is. But you have to be careful, because you don't want to scuff the medial femoral cartilage, especially when you are drilling inside out femoral tunnel. The posteromedial and the posterolateral portal, I am not going to say about, because now everybody is taking it. So, and it is very beautifully demonstrated by 2 portals on the medial side by previous speaker, and it is a very wonderful presentation. And as I told you, that don't hesitate in taking in posteromedial and posterolateral portal, especially when there is an old fracture and when you have to do a PCL reconstruction in revision cases. In child, if I have to do a PCL reconstruction, then I don't hesitate in taking a safety incision on the posteromedial side, put my finger inside and do the drilling and tunneling. The graft length has to be 90 or 100 millimeter. And that is also I do when I do bone-to-bone PCL very occasionally, but I like to do it. It is difficult, but it is not impossible. And of course, the peroneus longus graft has become a boon for the PCL reconstruction because there is the femoral footprint is so big. So you have to do a wide femoral footprint, and that is why the augmentation has given very good results in my hand. Because we all know that more collagen better is a better graft optic. The killer turn, which everybody is doing, usually we do around 45 to 50 degree angle ACL, but here I do a 60 or 65 degree, and that makes slight more easy for me. And this is even I can do a bone patella bone, as you can see here. And the tunnel dilators are the most important part of the armamentarium after the PCL elevator. This is a posteromedial bundle, and as I told you that if you have to take inside out, then you have to be very careful about the stuffing the medial cartilage. So outside in is better when you have to make a femoral tunnel for the PCL, and you can do either you can do any fixation that you like, but when you do outside in, most of the time I use bias tool. Tibial tunnel preparation, as we know that always you keep the drill and the drill tip partitioning in, and you always use this elevator to protect your, and you don't be shy in using IITV, especially in the younger kids. Wire loop passage, as we know, you don't need many fancy things. You can have a crochet hook and a simple number 24 wire loop that we have been using for many years, and this is economical as well as a shortest way. Nothing breaks, even not the fibers. Sometimes the fibers they also break. And for me, it is very easy to pass from tibia to femur, and I use this Arthrex spade tip passing pin, and by this you can pull the wire through both the tunnels very easily. For me, on the tibial side, the suture disc fixation is very good for in my hands, and that is what I usually like to do it. That a suture disc or a D disc, it is economical and it gives very solid fixation. And so, and of course, we all use this PCL brace for around 4 to 12 weeks, depend on which ligament and how many ligaments I have done it. And my rehabilitation is very slow. So for all this graft and for all these years, my PCL rehabilitation is very slow, and I am very clear with the patient that the physiotherapist cannot overrule my instructions, and that is very clear. So one should not do arthroscopic PCL reconstruction. These are the few things that has come to my mind, and I know that everybody knows. So because I don't want a vascular injury and further problems, if I cannot make them all right, I don't want to make them burst. So, and this is the youngest PCL for me is 3.5 years with the mother's graft. Of course, this has been now, she's now around 14-15 years full graft. So even in child, you have to see the PCL because they do have problems with the untreated PCL. Because this girl, she came one year after her injury somewhere near in UP, and then she has become all right with the PCL reconstruction. So thank you very much. Once again, I thank all the AP members to give me a chance to be with you and to do this small presentation.
Thank you, Nishith sir. It's a privilege that you are with us. So now we can ask questions and have clarity about what we have listened with the speakers. Is there any question with anybody? Dr. Ramakanth, there's a question for you. Dr. Ramakanth, you there? Dr. Ramakanth, you there?
Yeah, Ramakanth is there.
Okay. So Ramakanth, we have all seen that video by that technique by Dr. Dinshaw, where he uses fiber wire, puts some knots and fixes with more or less the same technique. So you're anyhow using fiber tape, which has a bigger and broader surface area of contact, gives a better compression. So what is the need of adding on the Indo button with a fiber wire along with using a fiber tape? So have you encountered any problem with using only fiber tape or fiber wire? That's why you have used additional fixation device? Ramakanth, you have to unmute yourself.
Yeah. To begin with, actually, we have been using this only fiber wire initially. So I learned these techniques from Sundar sir. So I've seen that Sundar sir beginning probably in 2015 or something, when he started, we had started using with the fiber wire. But what happened was there was a lot of slippage, and sometimes the fiber wire used to get cut, probably because of initial technical hitch or not. And then when the fiber tapes have started coming, so when we used it, so there was a good snug fit of the PCL around the neck of the PCL to the attachment of the fragment. So since the fiber tape is a broader one, so it had a good control and good like tight noose around the fragment. So that when we try to pull, so that gives good compression on the fragment. So that was one thing. And then when we started using the fiber wire with the button, so there were some 3-4 cases where probably because of the instrument or something, and fiber wire getting damaged, and then it used to get cut. So that's why we moved to the fiber tape. That was the first part of the question. And then the second is we have used both just to get a double fixation, as I told in my presentation. So when we put the button and then when we try to pull it, because initial few cases, there was some secondary laxity when we saw in the patient's follow-up. So initially when we started, there was a secondary laxity. So that's why double fixation and then triple fixation with the suture post we had put. Yes, sir. Nishith, sir.
Ramakanth, that laxity was clinically bothering the patient?
Yes, sir. Clinically, it was not bothering the patient, sir, but it was like grade 1 or grade 2 posterior sag, which we feel in most of the follow-up patients. In PCL reconstruction, either because of grafts stretching out or the strength of fixation was not sufficient, sir. So it was not clinically significant, but when we see the patient during the follow-up, we can feel some laxity in the PCL fixation. And as I told, we have published that there were some 2-3 cases of non-union as well in arthroscopic fixation as well. So that's why we have evolved to put the button and also the suture post to give good strong fixation for the PCL, sir.
Okay. Okay. And what is the rehab?
Rehab, we keep it absolute no mobilization of knee for 3 weeks. And then after 3 weeks, we start prone knee bending, sir. And non-weight bearing or touch weight bearing for 6 weeks, and then partial weight bearing for 1 or 2 weeks, and then full weight bearing from 7th or 8th week onwards, sir.
Okay.
One comment, Dr. Ramakanth.
Yes, sir.
I have done few of the PCLs repair, very small number. But what I could see that the tunnel which you were making were on the sides of the crater. I suppose that I
below on the side of the crater.
Normally, I try to make it approximately 2 to 3 millimeters below. The purpose is it pulls the fragment back to its crater. And secondly, I always use 2 fiber tapes, not 1. One, as you have mentioned rightly, we circle around, put a knot, and use it as a holding fiber tape. And the other one, what I do, I'll take your this ultra first pass mini device, is a small device, and just pass that fiber wire through the substance of the PCL, and then you take it back and you cross it over and take out from the different tunnel. The medial one will go lateral, lateral will go, so that it creates a cross over the bony fragment and puts it back into its position. I think with the fiber tape, things have changed, and definitely we have evolved as far as PCL fixations and repairs are concerned. And with my limited number, I have not faced any major issue. But my patient, they are low demand patient, and maybe I'm able to get away with that.
Yes, sir.
Ramakanth, another small technical tip. So
Yes,
you're using button with the fiber wire, correct? And the fiber wires are passing through infromedial and infralateral tunnel, which is outside the crater, correct?
Yes, sir.
So if there is a problem when you are trying to manipulate and maneuver the button over the fragment, it might just try to go down. So do you have to maneuver a little bit?
Yes, actually, yes. There's so many occasions where the button used to come below the fragment. So what we do is, so we put a suture retriever and then lift the button, keep it on the fragment, and then ask our assistant to pull it slowly so that the button doesn't flip outside the fragment. So it has happened many times, and it keep happening every time actually. So we have to ask our assistant to pull either medial wire or the lateral wire sequentially, so just so that the fragment is reduced and also the button is placed posterior to the fragment.
Yeah, one last question. You said that one patient has this vascular compromise in your case. What exactly happened? Can you share with us so that we are more sure what not to be done?
Yes, yes. So that case actually we had from past 5 years, probably we would have done around 35, I think, mostly by Sundar sir, and I've been doing only since last 2-3 years. And that case, there was a venous injury. I think the popliteus vein was injured because from the shaver, and then we found it immediately in the post-op, and then since the Ganga plastic team is well versed with this, so they had come in and then repaired it. So there was a gross swelling. Those clinical photos also has been put in that paper. So we had one case so far of probably 35 to 40 cases.
Yeah, thank you,
It is little technically demanding, and we have to be careful.
It is very technically demanding. And Dr. Sanjay, you said that you put a suture through the substance in the popliteal fossa?
No. From anterior side. From anterior side, I use
that is what I usually do. That two sutures through both the bundles, and then just pull it on the back side and then pull it out.
Intra-substance, it will not slip, it will not bite out, and you are not strangulating the ligament.
Absolutely.
To circling.
So my problem attention for the Dinshaw technique was that it was too much strangling of the PCL, you know, with all this so many knots, and then when you pull. So whether you say that there is a sliding knot or not, but probably they will become tight when you pull those knots, you know. So that was I had always apprehension about a Dinshaw's technique.
I cross the fiber tape over the bone and then pull it. So actually, it will not have a constructing effect.
Right.
So we have a question in the chat box. What is the ideal PCL graft thickness for reconstruction? Dr. Vijay asked this question. Ramakanth, Nishith sir, what's your take about this? What's an ideal PCL graft thickness?
If somebody is going to do only PCL reconstruction, then around 9 to 10 millimeter will be the ideal thickness of the graft. But nowadays, lot of I do is augmentation, especially anterolateral bundle, and that is why even 7 or 8 millimeter graft is sufficient, because you have all original fibers with you. Just you put augmenting on this, and that becomes because otherwise what happens that Sanjay bhai, I wanted to ask you, or Ramakanth, I wanted to ask you that if you do augmentation, if you put too thick graft, do you face any problem of postoperative knee stiffness, and you have to do a manipulation or anesthesia?
No, sir, we have not encountered any of this sort, sir.
But do you do augmentation?
Augmentation for PCL, we don't do.
That is what. But the thing is
Augmentation
that,
with the fiber tape, sir. Ask. Augmentation with the fiber tape you are asking.
No. Augmentation in the sense that I keep the original PCL.
Original PCL. Okay.
And then I just put the new
Biological
PCL,
augmentation.
PCL, you know.
Yeah.
Yes, sir.
That is what I'm. But that what happens that it makes the notch more. There are a lot of fibers along with the ACL,
Yes,
and that is why I have to do a manipulation after 2 months, 2.5 months in a few patients.
No, probably we have not encountered, because most of the time probably we are removing the remnant fibers as well to get a clear view, and we are going to put a 10 mm minimum diameter of it, because both semi-T or sometimes semi-T and both gracilis we put in a multiligamentous situation. Now the peroneus is also there, so peroneus with some gracilis to get the diameter 10. So we have not got a stiffness as such, sir, but the laxity we have seen in few cases.
So you use BTB.
Is not strong.
Use BTB.
So, Ajeet, Dr. Ajeet. So, in your presentation, you stated that you have to correct the bony deformities or bony abnormalities first, and then go ahead with soft tissue repair of MPFL. Correct?
Yes, sir.
So, in a scenario of valgus knee, when the patient has both the knees valgus, and you have a significant valgus, so you correct the valgus on one side along with doing an MPFL. So, what happens to the other side? Because now the patient has an asymmetrical kind of presentation. So how do you go about it? A valgus knee with an patellar dislocation or recurrent dislocation patellar, you want to repair an MPFL along with doing a correction of valgoid deformity.
So I feel it. If we are reconstructing, abnormal side, we have to go for a valgus correction first, then MPFL correction, and at the same time we have to tell the patient that your other knee also required a valgus correction, so that prior the future chances of MPFL injury can be reduced or subsided.
So Sanjay sir, your take is same, that you want to correct the valgus in the other normal limb, you want to correct the valgus, or you would only go ahead with the correcting?
Right now, patient is there for a problem in one knee, and if you don't correct the bony deformity, it is bound to fail. My reconstruction is bound to fail. So we have to focus on that, with a caveat that I'll tell my patient that the other side also requires correction, depending on the stage, depending on the age of the patient, whether it just requires a epiphysiodesis or something, a smaller procedure, maybe bracing, and that can help. So it all depends on actual clinical situation, but I would definitely advise a correction on the other side also.
Yeah, Dr. Rohit?
Yes, sir.
So you had any problem of restriction of range of motion or maybe a tight knee when you're doing a, because the only thing is you don't know how much are you tightening on the lateral side when you're doing a tenodesis. So any tips and takes about how to avoid that over tightening on the lateral side when you're doing this technique?
Yeah, so the most important reason of over tightening initially was when we were doing it in the external rotation, the fixation of the LET graft in the external rotation of the tibia. So you have to keep it in 30 degree of flexion and in neutral rotation. At that time, it won't be over tightened. And also while closing the TFL gap, at that time, you should not make it over tightened. So that reduces the lateral compartment pressure significantly.
So
if you see the original Lemar technique, he used to use staple.
Yeah.
Those were not used. And there is a recommended technique that you just hold that graft, you don't pull it. You just hold it so that it acts as a restraint. It is not pulling the tibia back. And once you put in a staple, it will not. Sometimes what happens when you are putting a screw inside, your graft gets tightened. Your graft goes more into the tunnel. So we have to be really careful when inserting a screw.
Yes, sir, definitely. You don't have to apply extra force from the other side to make it.
That's a normal tendency. When we want to do reconstruction, we want to do it tight so that we are happy that things are stable. But here we have to be happy keeping it a little loose.
Yeah, it should be lax, means it should not be too much tight.
Yeah.
Nishith sir, you wanted to add something, I think. Sir, your voice is not there. Nishith sir.
Mic is not working, I think.
Okay. Abhinay, Dr. Abhinay.
Yes, sir.
So what's your choice of distal fixation on the tibial side? You would like to fix it with a tunnel on the tibia, or as you showed that you would like to use a staple there?
Sir, I think now screw is better, sir. Tunnel, using tunnel is better because bony to soft tissue fixation is good. That will be good, better. But because due to cost, I have to use the tunnels, staples.
But I feel when you are attaching the superficial MCL, you have a very large area of fixation. So if you use either some kind of spike washer or something to stabilize to its natural position, that can work very well. I use that in cases of superficial MCL avulsions from distal side.
There is a comment by.
There's a comment by Dr. Nagaraja that while doing arthroscopic PCL avulsion fixation, is it must to get hairline reduction of the fragment like an open fixation? Because sometimes post-operative X-ray shows fragment not reduced 100%, but the intraoperative we would have found restored ACL tension as well as the PCL. So is it required to go and get absolutely 100% reduction in cases of PCL? Because I think Sanjay sir and Nishith sir are from the times when PCL was handled more or less conservative. Now it is more or less operative. So they are in the best place to answer this question, either of the senior most guys.
We have seen the conservative era, we have seen the open fixation era, and we are working in the arthroscopic era now.
So do you want to get this hairline 100% reduction of PCL, or?
It is not always possible when you do it on arthroscopic. Stability is first thing. I want my bony fragment to sit in the crater so that it get an environment and ultimately it can heal to a larger extent. When there's a very large bone fragment, fresh fracture, you might get a hairline reduction, but that is not the aim. The ultimate aim is to provide a stability and a bony contact. That's it.
Even in the chronic avulsion after 2-4 months, if you clean the crater and do some refreshening, you might see a gap, but if you see clinically, there is no problem with patients.
Yes, one I would like to add a point on it. So actually, that's why in our initial cases, I told there was few cases of non-union because we are not able to achieve the 100% reduction. So that is when we started doing this double and triple fixation, where first we just pulled the fiber wire and then tied it in the anterior cortex. Then we had added the button and then tried to pull the fragment again and then tied it in the anterior cortex and then the suture post. So each time when we tighten it, so probably the reduction was better. So after this triple fixation, we have not seen any cases of non-union so far. So
how much time it takes to do the triple fixation?
Sir?
How much time it takes you to do triple fixation?
It is a bit longer, sir, but our operative time now it's like 1 hour to 1 hour 15 minutes we will be able to do. Mainly initial phase is what first half an hour will be like concentrated mainly on clearing the soft tissue and getting the identification, half an hour to 40 minutes. After that, putting the wires and then pulling it takes just about half an hour, sir.
Okay. Okay.
So half an hour to 45 minutes is just to get the anatomy clear so that identify the fragment, identify the posterior cortex, and then clearing with the RF probe takes time.
What I understand that once we are doing these repairs, your fragment is like this and your sutures are going on the sides. So many of the time that fragment lifts and it's difficult to contain that. That's why I prefer to keep my holes down there and not so far lateral, so that my fiber tape is actually pressing the fragment to it.
Yeah.
As I said, when they are crossing like this, they also create a buttressing effect on the fragment. So that prevents the lifting of the fragment, which is very common after PCL repair. And I think that is the answer for your this problem.
Sanjay, do you put any like Steinman pin or something in the posterior and retract the capsular part or the posterior part?
I normally do both medial lateral. So
okay.
That's comfort.
That is compulsory. Yes, if you want to do PCL avulsion.
Sometimes I just put in this Visinger rod and you put
I think that Visinger rod makes life more easy. You know.
Definitely.
Rohit,
you are working in a better.
So in your case, you showed that you had to the tibial tunnel was at fault. Suppose you have to do the same case with the femoral tunnel, which is abnormal, and you have to recreate a femoral tunnel. So would you give any tips of then doing a tenodesis, because then you have already 2 tunnels on the femoral side for the ACL? Would you like to make some changes in your technique, or you would still go ahead and make another tunnel for tenodesis?
So as I have shown in my video also, you have a modified McIntosh procedure. So you can do that if you are not very much confident whether you can use a femoral tunnel. So, and the other option is also the staples, as sir told that initially that it was described with the staple only. So you can use either a staple or you can just revert it back on the Gerdy's tubercle and just tie it up. So that is another option, but initial thorough planning is more important. On the CT and everything you should plan beforehand that you can use it or not.
You can use that McIntosh technique, or you can use that Sebastian's modification of McIntosh, in which you loop it through the septum and bring it back to the tendon and suture. That is also a very good technique, because you need not to work on the bone, and then there's no problem of confluence of tunnel or those things.
Yes.
The only trouble is you need a longer graft.
Longer.
So I think we have crossed 9 o'clock. So thank you Ortho TV for giving us wonderful platform, and I would like to request Dr. Karmaraj, our VOC secretary, to give in the closing remarks. And I thank everyone to be who have participated in this event. Dr. Karma, please go ahead. I think we can't hear you, Dr. Karma. No, your voice is. No, you're not. We can't hear you, Dr. Karma. So you have to unmute yourself. Okay, you have unmuted.
He has unmuted. There's some problem with the mic, I suppose.
So, okay. So thank you, everyone. Dr. Karma, we can't hear you. So sorry. So I'll address everyone on behalf of yours.
Okay, no problem.
Yeah. We can hear you. We can hear you. Go ahead.
Okay. Yeah. Thank you so much, AAUP and the President, Secretary. I mean, you've done a great job of getting forms. It has been so kind of Dr. Sanjai Srivastava and Dr. Nishith Shah to preside over as panelists, and excellent talks by Dr. Rohit Pandey, Dr. Ajeet Singh.
Okay. So we will wind up. Thank you, everyone. Thank you, Nishith sir. Thank you, Sanjay sir. You have always guided us. Keep guiding us more and more.
Yeah.
And,
okay,
great. So now your voice was again gone in between, Dr. Karma.
Oh, yeah.
Again, it is gone. So Ramakanth, we will be surely coming to Coimbatore, and I think all of us who are there on the this meeting, we all will be coming to Coimbatore and seeing you there. Thank you, Rohit. Thank you, Ajeet. Thank you, Abhinay. You have been wonderful. All presentation has been wonderful. I'm absolutely amazed to see such wonderful presentation. When we were like 10 years back, we could not present like this. Absolutely hats on.
We are being modest here, sir. Thank you so much.
No, it's wonderful. Thank you so much. Good night.
Okay, good night.
Good night, sir. Good night, everyone. Thank you.
Good night, everyone. Good night.